Perfect. Thank you, Francis. And thanks for inviting me today to talk about ethical issues in pragmatic trials. So by the end of this talk, my hope is that everyone will understand what are pragmatic trials and why these trials raise complex ethical issues. And I'm also going to present a framework for pragmatic trials, which I hope will be useful for those of you involved in their design, their conduct, and their review. So as many of you will know, randomized controlled trials can be either explanatory or pragmatic. An explanatory trial is aimed at understanding. It seeks to determine whether a treatment like a new drug or new device works in optimal conditions. So to answer this question, researchers aim to recruit a homogeneous group of research participants based on strict eligibility criteria. Eligible participants are then recruited through a targeted effort, such as sending letters, advertising in newspapers, or on social media, using incentives or other means. These trials often occur in single academic or specialized centers, and they require increased staff levels, additional training, and more resources than what is normally available in routine clinical practice. There is often a strict protocol and additional monitoring and measures to improve compliance. There are often exclusions based on adherence and measures to improve adherence if necessary. Explanatory trials typically have more frequent or longer follow-up visits and more extensive data collection procedures. The primary outcome is often a surrogate physiological outcome, and the analysis often includes only completers and those following the strict treatment protocol. But in the end, explanatory trials provide an answer about the efficacy of the novel treatment for a select population in optimal conditions. And these trials play an integral role in the development of new healthcare interventions, right? This is because if an experimental intervention is proved to be inefficacious in favorable conditions, then researchers have essentially refuted a mechanistic hypothesis. But because of all the design features that I've just outlined of an explanatory trial, if the experimental intervention demonstrates signs of efficacy, the results cannot be directly generalized to justify using the new intervention in routine clinical practice. This is in part because the broader patient population is often substantially and meaningfully different from those who participate in a trial. So how do we generate evidence to support the decisions of patients, of health providers, and health system managers? This is where pragmatic trials come in. So pragmatic trials are aimed at decisions rather than understanding. Right? Essentially, they're designed to answer a question about whether an intervention will work under usual everyday conditions. And these trials differ in important ways from explanatory trials. A highly pragmatic approach to eligibility would be to include everyone with the health condition of interest who is likely to be a candidate for the intervention if it was being provided in clinical practice for the condition. A pragmatic approach to recruitment would be to enroll all or most people who present on their own behalf to a clinic with the condition of interest. These trials are often multi-center and conducted in an identical setting to which the results are intended to be applied. They do not require highly specialized training or additional research personnel or resources other than that which is normally available in routine practice. These trials also allow health providers to deliver the intervention without a rigidly prescriptive protocol, similar to how it would be delivered in routine practice. There is also no more than usual encouragement to adhere to the intervention, no more than usual follow-up procedures. The primary outcome should be of obvious clinical importance to patients or to participants, and all randomized participants are included in the analysis. So doing this provides an answer about the effectiveness of an intervention for the general population in the messy conditions of routine clinical care. It's also important to understand that trials are rarely purely explanatory or purely pragmatic, right? The choices that are made within these 9 domains that I've just described can make a trial more explanatory, right? Looking something like this, or more pragmatic, looking something like this, right? But this pragmatic trial is different from, say, this pragmatic trial in important ways. And the reason it's important is because ethical issues are inextricably intertwined with design choices and are tied closely to the intervention being evaluated in a pragmatic trial. So let's start with these 4 design features. What do they tell us about a pragmatic trial? Well, first, researchers should be recruiting all or most patients with the clinical condition of interest. Second, to minimize the need for additional resources, researchers may rely on health providers and their usual experience or expertise to recruit prospective participants during routine clinical encounters. Finally, researchers should be mirroring routine settings, which means that the workflow of busy clinics shouldn't be disrupted by the research. So one problem is that these features potentially conflict with the standard informed consent process that many of us are used to in research. Now, to be clear, informed consent is an ongoing part of research that involves identifying eligible participants, discussing the trial with them, maybe giving them a form to read, to think about, to ask questions about, to sign and return, and then making sure that they do not withdraw at any point during the trial period. The concern is that every step of this consent process leads to people refusing to participate or withdrawing from the trial. The rule of thumb is that for every 10 patients asked to participate in a clinical trial, only 1 will remain throughout the entire process. And if recruitment and retention is too low, it can reduce the generalizability of the trial's results, which undermines the aim of conducting a pragmatic trial in the first place. Moreover, informed consent is typically obtained by specialized research staff, and requiring additional staff and resources will again make the trial less pragmatic. And having a consent process may disrupt the workflow of busy clinics, and deviations from clinical practice are to be avoided in pragmatic trials. So these design features demonstrate a clear conflict between a fundamental ethical requirement like informed consent and the conduct of pragmatic trials. Another ethical requirement of research that potentially conflicts with pragmatism is the need to identify and protect vulnerable research participants. Now, vulnerability is a technical term in research ethics that should be distinguished from its colloquial meaning. Vulnerability or vulnerable research participants are people who may have an increased likelihood of being wronged or of incurring additional harm because of participation in a particular study, and for whom the standard ethical protections do not suffice. For example, young children are vulnerable because they have limited autonomy and thereby lack the capacity to consent. All individuals, not just children who lack decision-making capacity, must be identified so that additional protections can be put in place when they're involved in research, such as soliciting consent from a surrogate decision maker. Another example is individuals faced with physical frailty due to age or comorbidities. These individuals may be at an increased likelihood of experiencing harm in research. Additional protections for these individuals might include allowing no more than minimal risk for research procedures that offer no potential benefit for these participants. A final example is socially marginalized individuals, such as ethnic and racial minorities, people experiencing homelessness, refugees or displaced persons, and people living with disabilities or impairments. Obviously, protections need to conform to the particular vulnerability. So if, for instance, people who don't speak the same language as the research team are included in a study, an additional protection would be to have a translator present, right, to make sure all documents are translated to the participant's native language. While the identification of vulnerable research participants typically occurs during the recruitment process, a recent systematic review of almost 2,000 pragmatic trials published between 2014 and 2019 found that about 9% of pragmatic trials reported that consent had not been obtained or was waived. So if there is no recruitment process and all patients with the clinical condition of interest are included, this increases a trial's pragmatism, but it makes it much more complicated or potentially impossible to identify vulnerable participants. If researchers build in eligibility criteria that excludes potentially vulnerable participants, the trial will be less pragmatic, and it is ill-advised to exclude people from research without a valid reason. Being vulnerable, to be clear, is a reason to implement additional protections, not a reason to exclude someone from research. Conversely, if researchers maintain broad eligibility criteria, they recruit all comers, implementing additional protections such as soliciting consent from surrogate decision makers or hiring translators, translating documents, this will likely require additional resources and disrupt workflow, which makes a trial less pragmatic. Again, these design features demonstrate another clear conflict between a fundamental ethical requirement, like protecting the vulnerable, and the conduct of pragmatic trials. As I said before, not only do these design features of pragmatic trials potentially conflict with ethical requirements, but the interventions commonly evaluated in pragmatic trials complicates their ethical analysis. Many pragmatic trials compare the effectiveness of interventions that are already used routinely in clinical practice. For instance, there was this TIME study, which was a pragmatic trial that randomized adults who already have hypertension and who already are taking at least one antihypertensive medication to take all of their usual medications in either the morning or in the evening to see whether evening dosing improves major cardiovascular outcomes compared to morning dosing. So in this example, people were not taking new medications with unknown side effects. They're continuing to take the medication they usually take. Maybe it's at a different time than they normally would, or maybe they're taking their medications at the time they normally would. There were no invasive data collection procedures or many follow-up appointments. Rather, anonymized data from centralized national databases were used for most outcome measures, and participants were asked to complete a brief online questionnaire every 3 months for 5 years. So what are the risks of participating? I think many people would feel fairly confident in saying that a study like this poses no more than minimal risk to participants. And this assumption holds true, I think, for many pragmatic trials evaluating interventions used routinely in clinical practice, right? If, say, many people are arbitrarily taking their drugs in the morning or in the evening, what risks are introduced by randomizing people to take their drugs in the morning or in the evening, right? Many people assume none, but this is far from clear, right? The outcomes of this study included vascular death, hospitalization for non-fatal myocardial infarction and non-fatal stroke, and all-cause mortality. Can a study that aims to see if less people die be considered minimal risk? What if a person who typically takes their medication in the evening and rarely experiences any side effects is randomized to take their medication in the morning and experiences increased levels of fatigue and headaches, right, during the day, and as a result finds it difficult to perform adequately at work? Should this be considered minimal risk? My point here is that the benefit harm analysis ends up being more complicated than initially thought. And it isn't safe to assume that pragmatic trials which evaluate interventions used routinely in clinical practice pose minimal risk. Another reason why interventions may raise ethical issues is because, as it turns out, about 44% of pragmatic trials evaluate behavioral interventions. For instance, a pragmatic trial may evaluate whether teaching health providers novel hand washing techniques and place additional hand washing stations around a hospital can reduce the prevalence of bloodstream infections in patients compared to usual hand washing practices. But to evaluate this kind of intervention, hospitals can be randomized, professionals then intervened upon, and patients observed for outcome measures. In other words, a cluster randomized trial. And as it turns out, about 35% of pragmatic trials use cluster randomization. Now, cluster randomized trials raise complex ethical issues, which Charles will talk about in the next presentation. Suffice it to say that most researchers, research ethics committees, and policymakers are unfamiliar with what these issues are and how to address them appropriately. In addition to the ethical issues I've just described, there are other issues that could arise in pragmatic trials. So where should you look for guidance? The thing is, existing regulations were developed for explanatory trials, not for pragmatic trials. And so looking at most policy and regulatory documents may not provide adequate solutions to the ethical issues you face when designing and conducting pragmatic trials. So instead of looking to regulations when I'm asked or consulted to help through ethical issues in pragmatic trials, I return to the ethical principles upon which these regulations are based. You'd likely have heard these principles before. They include respect for persons, beneficence, justice, and respect for communities. And each of these abstract ethical principles gives rise to very specific obligations that researchers have to both individuals and communities involved in research, but they do so at a level of abstraction that confers a considerable amount of flexibility. So let me explain what I mean. Respect for persons incorporates at least two ethical convictions. First, that individuals should be treated as autonomous agents, and second, that persons with diminished autonomy are entitled to protection. So this principle gives rise to two obligations. Researchers must obtain the informed consent of prospective research participants, and they must protect their privacy and confidentiality. The term beneficence is commonly understood to cover acts of kindness and charity, but in the context of research, like the concept of vulnerability, this principle means something more specific, namely that people must both be protected from the harms imposed by research, and efforts must be made to secure people's well-being. Even more specifically, two obligations. First, researchers must demonstrate that the study interventions satisfy equipoise. In other words, that there is in fact a genuine uncertainty among the relevant expert community as to the comparative merits of the study interventions. And second, that the risks of data collection procedures are minimized and reasonable in relation to the knowledge to be gained from the study. The principle of justice is about treating people fairly. For our purposes, justice is a question of who ought to receive the benefits of research and who ought to bear its burdens. Again, two obligations. Researchers must demonstrate that participant selection procedures are fair and that they must identify and outline protections for vulnerable participants who are included in research. Finally, respect for communities is about understanding that intact social groups have interests or values that may differ from the interests or values of their constituent members. The responsibility that falls on researchers to be able to recognize and respect those interests and values. The term community itself is meant to delineate a wide variety of human associations, from tribes to municipalities to ethnic, racial, or religious groups. Again, two obligations. Researchers must respect communal values, which is often accomplished by engaging and empowering social institutions, and researchers must seek permission and abide by the decisions of legitimate communal authorities where appropriate to do so. There is a lot here to digest, and I can easily spend an hour or more discussing each of these obligations. We clearly don't have time for that, so I'm going to conclude by suggesting a few things to think about related to pragmatic trials. To show respect for persons, consent must be obtained. But as I said before, the standard written informed consent process may not be ideal. Have you considered approaches to consent that can allow people to decide whether to participate in a pragmatic trial while also achieving high rates of recruitment, right? As we've heard before, maybe electronic consent, maybe an integrated clinical style consent process. Also, have you clearly outlined a plan to safeguard the privacy of participants and the confidentiality of the information used for research purposes? To assist with the benefit harm analysis, have you demonstrated that equipoise exists between study interventions under evaluation? You could do this through demonstrating conflicting evidence, through variations in practice, maybe both. Have you outlined potential benefits and foreseeable risks that are attributable to research and distinguish those that are related to practice? To uphold the principle of justice, have you been appropriately inclusive in selecting participants? And have you provided clear and valid reasons for all study eligibility criteria? Have you identified potentially vulnerable participants and outlined protections for them? And to respect communities, have you partnered or engaged with the relevant parties with some vested interest in research? And will you seek permission from local gatekeepers, be they the directors of a medical facility or village leaders or school principals? And have you or will you involve relevant community members in the study design, conduct, and analysis of your study and the dissemination of its results? Clearly, there's a lot more to discuss, and I look forward to the Q&A. For now, thank you for listening, and I'll hand it off